All right, so the program says I'm supposed to talk about ISYE science, but I won't, and I apologize to disappoint you. Instead, I'm going to talk about human factors contributions to patient and family engagement, which hopefully is also an interesting topic for everybody here. And it's a very simple message that I want to deliver and hopefully inspire you, motivate you, and then start talking about it this afternoon and later this morning and maybe throughout the year until we meet next year. So the premise is this third bullet point, but let's start with the first two arguments on this page. The first one is circa 2000, the turn of the century Institute of Medicine report to Aris Humans saying human factors can contribute to healthcare, what it has done for aviation, nuclear power, petroleum, road transportation, and other industries. And this was kind of the launch of human factors in healthcare on a larger scale. And then as we learned on Sunday at the opening reception, around the same time, John Beasley and Betsy Karsh and others were saying human factors can contribute to primary care specifically, the kinds of things it's done in other industries. Today I want to talk about how human factors can contribute to patients and families, what it's done for professionals, including those pilots and more recently physicians, nurses, and other healthcare professionals. But what is human factors? I mentioned this a little bit yesterday, but so at the top of the slide is the paper that Betsy Karsh wrote with his graduate students in 2006, attempting to explain what is human factors and how can it be useful in healthcare. You see that the quoted text at the bottom, the really massive long quote. You think that's an extract from the paper. It's not. It's the first title of the paper that Betsy suggested until the editor said, no, you have to cut it down a little bit. But this is like prototypical Betsy. He wanted to stick the entire message into the title of the paper to make it easier for people. And what he said is, so the road to patient safety runs through the provider, and so design work systems to support performance and also reduce hazards. And so he defined human factors, and there's good precedence for this in the literature and in our society's definitions of human factors, that it's all about supporting human performance, okay? And also, as an aside, if you want to support human performance, you need to understand human performance. And so things like workflow analysis, which Tally mentioned yesterday, or Tasha was talking about yesterday, going and shadowing primary care providers during visits with patients who have been recently hospitalized. This kind of work is necessary in order to be able to support what goes out in the field. We have a number of methods with which we study and attempt to improve the work of people or the performance of people. I did a word cloud just to try to condense some of this information. We do a lot. We've actually developed a very broad and sometimes very deep toolkit for methods. We've actually also collected a bunch of methods from other disciplines like sociology, anthropology, kinesiology, human-computer interaction. And so there's certain things that we're known for in human factors like task analysis and workload assessment, usability, that are tried and true methods. But we also have a lot more than some people sometimes don't realize how diverse we are, like the measure and the training on communication, visualization. We have here incident and error analysis. So quite a bit. We've been applying this in healthcare, as I said, since the turn of the century, but actually probably since the 1960s, maybe even a little earlier. We just don't have the evidence for it. But the way we've been doing it is, and not to take away any credit from the work we've done in the past, but we've been focusing on, as you can see in the title, and of course, you can't see the animation. Oh, here it comes. You got it. Excuse me. So the focus has been on applying human factors to supporting the performance of the healthcare professionals, sometimes to the exclusion of the patient or the other person in the room. And that has actually been a fruitful body of work. But as we move forward in this new landscape of patient involvement, family involvement, we're starting to think about how can we apply human factors to support the work of both healthcare professionals and patients, as well as their family members. The paper that I just showed you, there are several authors on it who are in the room or at the conference, and this is just kind of the latest version of the SEEPS model, which you may have been already familiar with, stands for Systems Engineering Initiative for Patient Safety, and we introduced SEEPS 2.0, which is it's got some fancy new bells and whistles, but mostly the point of it is to focus our attention on the work that's done by patients and families, as well as the work that's done by healthcare professionals. Just to take you through it really quickly, on the right side, you can see that there are a number of outcomes that are important, and that they're shaped by the performance processes in the middle, which themselves are shaped by this interactive work system of multiple elements on the left side, which maybe looks familiar to a lot of you. But I really want to focus on the middle, which is, the types of processes that we might focus on, and we divide it into 3 types in the middle, and the arrow there, starting with professional work. And again, that's the very traditional type of work performance that human factors has been applied to in healthcare. If you imagine this as an analogy, or the metaphor being, we have players on a stage in a theater. At the front of the stage is the clinician or the healthcare professional, and then the patient or the family is not an active participant, although they may be there, but they're at the back of the stage or maybe behind the curtain. So that's professional work, for example, putting in information into a medical record at the end of the day, and you're just documenting things. There's no patient there. At the bottom is patient work. That's the second type, and this is work that's done by patients and families without much involvement or very minimal involvement from healthcare professionals. For example, managing a disease at home. Now the physician, nurse, they're there somewhere, but not in the room. And finally, in the middle, and maybe this is the most common type of work, we have collaborative professional patient work, where, for example, that person who is taking care of a chronic disease at home now comes into the office, and now they need to have a conversation. They need to exchange information, process information with their clinician. Both are saying things, both are ruminating on things. Maybe they're even making decisions together. So that's collaborative work. And the application of human factors to those latter 2 types of work is what we call patient-engaged human factors. And we would define it as the application of human factors, theories and principles, methods and tools, analyses and interventions to study and improve work done by patients and families alone or in concert with healthcare professionals. So if you see that word or that term again, that's what that is. So patient-engaged human factors is not about advocacy necessarily. How many of you are familiar with ePatient Dave? I see one hand. Any more hands? So some, but not all. I recommend that you read his book. It's a really easy read. It takes like 30 minutes. You can go on his website. You can Google it and find all of his videos on there if you prefer to look at the videos. He's a really engaging speaker. He has a lot to say, and as you can see in this latest book of his called Let Patients Help, he's got a message, and the message is, first of all, patients should be doing more, should be more active and engaged and involved. And secondly, the powers that be should let them do that. Okay, so it's really an advocacy message, which is great. And he says a number of things that I'll not go over, including that the culture is changing, and so this is coming. This is a train that has left the station. I like to put up this slide. This is the American Medical Association Code of Medical Ethics from its crude original beginnings to its current version. You can see we're talking about a change from the obedience of a patient, crude opinions, to taking an active role and being partners. So things are changing, and in fact, patients are doing things, right? All of you who are patients, know patients, see patients, you know that they do things, right? They move and walk and talk, and they take the bus to the office, and they They have to process information, they Google things, and then they have to take care of themselves, and they take pills. They do things. So I'm not all about making them do more, although I think other people are, and then maybe that's okay. I'm about what can we do as human factors as a discipline, and maybe industrial engineering more broadly, to support that. And so e-patient Dave talks about let patients help. I say help patients help. Can we apply our methods in order to make the work that patients do easier, more satisfying, and more effective? Maybe not as sexy of a title or slogan, but maybe more to the point, we can help patients work. So this is not actually a new thing by any stretch of the imagination. We've been doing this kind of work. I've put up some examples, and in fact, you should notice that some of the people who have done this work are in the room. I see Jenna over there and Enid. Is Pascal here? She, family-centered rounds with Elizabeth Cox. There has been work in this area, but maybe not recognized enough. So if you look at this list of names and you look at these projects or topic areas and you say, oh boy, I didn't know about this, then we haven't done a good enough job of advertising that human factors can do things to improve the work of patients and families. And also there needs to be more. So what I'm going to do for the rest of the time today, and hopefully I'll actually go through these slides a little quickly and try to get some discussion going, is think about at least 5 areas of contributions that human factors can make to patient and family engagement. As you can see, there's more than 5, but there's not enough time to talk about all of it. As I talk about these 5 areas of contribution, I'll use some examples from 2 studies, and so I want to give proper acknowledgement to the funding sources for those 2. The first one is a study with outpatient heart failure patients, and the second with patient family members who described to us non-routine events in the course of care. So the first contribution that I think is quite evident and right on cue, Pascal shows up, is the systems model. Perfect, well done. So the systems model is a famous tool of human factors, especially in applications in healthcare, primarily because of Pascal, right? She says no, but I say yes. And the idea is that instead of looking at one little itty-bitty component of the work system, personal characteristics and patients don't have knowledge, patients don't have motivation, patients don't have skills or abilities. We're now looking at that and a number of other things that are all interacting together, including the presence or lack of tools, the characteristics of tasks, and these are all actually integrated and interacting. So we can use models like this to answer questions such as what are the hazards or barriers to optimal self-care adherence, rather than maybe focusing on just health literacy or individual factors. To give you an illustration of that, this is a study that we did. This is a data analysis summary from 30 participants where we found 3,100 references to barriers to self-care. These are heart failure patients across 209 subcategories of barriers, and these were across the entire system, the entire work system, and not just under person. It wasn't just knowledge and motivation, although those were sometimes barriers. We won't go into the meat of the study or the details of the findings, but here's a depiction of what a patient work system might look like based on an analysis of what actually contributes to hazards in performance or difficulties in performance. And you can see there's actually quite a bit, and it's not all just the person. The other interesting thing that I pointed out is that work systems are about interactions, and so thinking about interactions can actually give us some insight into phenomena such as self-care adherence. And I'll give you this really quick example of an 85-year-old woman with heart failure that we saw in the home. Let me see if this works. Okay, so the first thing you'd ask is, well, maybe she doesn't know what to do. And now we're talking about exercise here, let's say. Does she know how to exercise? Does she know that exercise is important? And she does know that it is. She also is motivated to exercise, so good for her. But walking, a task characteristic, is difficult for her. And there's a reason for that. It's an interaction. She has a physical impairment. She also has fatigue, which is actually symptom of heart failure. Luckily, she can swim, and she happens to have access to a community outdoor swimming pool, which is, not everybody has that, so that's a nice, great resource that she has. But she has no car, so she's unable to get there by herself. Luckily, she has a son who is on disability and stays at home all day. He can drive her to the pool, and he's happy to do that. He's a great guy. But the weather gets cold in Nashville, Tennessee around August, right? At least in people's minds. And so the pool is closed, and she's unable to go to the pool. And again, luckily, she has a community resource that not everybody has, and she has the money to afford that community resource, a local gym with a pool. Unfortunately, all of this breaks down because when she gets to the gym, she says, there are all these young patrons there, and they look at me, and they see my surgical scars, and I just don't feel comfortable swimming around them. And so it's this social, environmental barrier that brings everything tumbling down. And so you wouldn't know this if all you were focusing on is, well, she just don't want to go exercise, right? So that's the systems model. That's one of the contributions that we can make. Secondly, the analysis of work tasks, processes. So I think Tally is going to do a session on this. We've already had some conversations about this from Tasha. There are ways that we can go and study the work that people do, including doing process maps. I won't go through this process map, but you can see this is about looking at a variance in which what happens depending on where a person is in the morning and whether they take an extra medication, and do they go out during the day or do they stay during the day. And in both cases, actually, they end up missing their evening medication, but for different reasons, except for in this third case where there's a caregiver present who says, hey, Dad, before you go to bed, take this medication, and brings it to them. So we can do process mapping. That's a fantastic use of human factors tools to try to understand the work. And remember what Tally said, right? If we don't understand the workflow, we can't design technology that's going to fit or support it. Same thing goes for patient and family work. We keep giving people medication reminders that tell them to take medications that they've already taken. How useful is that? Or they tell the patient that you should take your medication when you have no access to it, right? So it's a context insensitive alert that says, hey, you got to take your medication, but it's back home, right? And it doesn't know that, so it just keeps harping on you, and then tells you you've been bad. Same thing with the kind of alerts you might get if you're a primary care provider, right, or clinician. We can also look at where the work is done, which is very important. We can look at different contexts in which the work takes place. For example, at a friend's house where there might be no scales to step on and weigh yourself during the day, or you might feel self-conscious sticking yourself with a insulin needle. So the nature of the work really differs between these contexts. We can also look at types of work. And here you can see a depiction of, for example, in the upper left-hand corner, clinical types of work that a person might do. Below that, you can see some of the personal types of work that they do. And to the right are the logistical types of work that they do, which I like to say, these are the things that if patients and families had administrative assistants, if they were paid workers, that's who would do this kind of work, this kind of coordination, making appointments and scheduling and like calling the insurance company, complaining, things that are part of a person's workload. And we can also look at the interconnectedness of this. I'm not going to spend much time on this, but you can see a person's table. This is not from our study. This is from somebody else. All their health-related materials are laid side by side, and you can actually learn a lot about the nature of work by doing an artifact analysis like this. They've got their cigarettes, and then they've got their insulin, and they've got their telephone and their coffee. Workload and situation awareness, those two words go together, or those two terms. Tasha talked about that. John talked about that. everybody should look and appreciate this cartoon. It's real fun. So those are two constructs with which human factors engineers and industrial engineers deal with all the time. Starting with workload, I remember when John Beasley did his paper on the NIPIs, the number of problems per encounter, and he calculated the workload or inferred the workload that a clinician is dealing with. That workload also applies to the patient. The number of problems that they have is the number of problems they have plus the other ones they didn't mention, plus all the things that they have going on in their lives. So there are certain workload characteristics that patients and families experience that we could also measure. And the first thing we did, we tried to do to some extent after the NIPI study was to try to characterize workload in a more complex way, thinking about all the different demands that somebody might experience and all the resources that might weigh against it, with the balance of demands and resources being the ultimate workload. This can also be done for patients and families, right? We don't have to estimate just one characteristic, like how many hours do you spend on chronic disease self-management, which, by the way, is 2 hours is the mean, according to some recently reviewed studies. We can look at things like work volume, work complexity, time required, number of tasks, and efficiency in those tasks. And then we can look at situational factors, like in the moment when you're doing the work, are you distracted? Are there constraints on what you're doing? Are there conflicting goals or conflicting tasks they have to deal with? And then we can look at resources as well. Do you have a family member who's helping you or not? And I think if we can get an accurate portrayal of workload, maybe we can make better decisions in the clinical sphere. Or maybe we can use that as a good outcome, just like we use workload as a good outcome in some of our studies here in primary care. Just to give you an example, I really like this quote, so I'll put it up as an example of patient workload. This is somebody who's saying, I started coming out here, taking my blood pressure, taking my weight, sugar, till I feel like a secretary, and it aggravates the fool out of me. Get up in the mornings, it takes me 30 minutes to put my clothes on, to do the scales, to do this, that. And I ought to get me a degree. I'm almost a doctor. So people do this and more during the day. Situation awareness. The quick definition is the perception of elements in the environment, the comprehension of their meaning, and the projection of their status, or I like this short and quick version, the what, so what, now what. And one of the things that I found just fascinating in the two studies that I mentioned, kind of half expected that this would be the case, but not to the degree that it was that patients and family members just had no idea what was going on a lot of the time. They would, like, if you asked them, and nobody has, I think this is a deficiency in the research or a gap that we can address, what is happening now? Who is that? Who's that person that's seeing you? And what do they do? And what are you on? What medications are you taking? And what is happening? If you mapped out their awareness, I think they wouldn't do very well. And not only do they not know kind of like their plan of care necessarily, but they don't know the big picture. What is going to happen to me and who is going to take care of me in a clinical sense. I've got this quote for you from a focus group in our PCORI-funded study. I was in the emergency room, and I had a strep throat. My throat was literally closing up, and the nurse just came in and gave me an IV and some pills and said, I'll come back and check on you, all right? And I got to the point where I leaned back, and I couldn't breathe at all. I had to sit up to breathe, and I'm sitting there for an hour just sitting by myself, and I had a pad, and I wrote out, what do we do when I cannot breathe anymore? And this was typical. Now, this is quite an acute case, but this was actually typical of what we saw, where people would come into the doctor's office for a very routine thing, and they would end up in the hospital. They had no idea, and they thought, well, maybe I'm there just to get, a scan. And they're there for 3-4 days, and they're getting their heart replaced. And this is crazy stuff, and they're not aware. And I'm not blaming anybody, by the way. I'm just giving you kind of a sense that there might be issues with situation awareness that we're not necessarily measuring in a systematic way. A fourth area of contribution for human factors is to think about how can we facilitate teamwork. I like the analogy that the patient is the pilot, the caregiver is the co-pilot, and what does the clinician do? They're air traffic control, because for the most part, they're somewhere else, but they need to be involved. So I like that idea, and this is a team model. We had a conversation about this at HFES last year. Are they a team? Well, here's some characteristics of effective teams. They're interdependent. Are these teams interdependent? And by the way, the primary, patient-centered medical home is a team model, and a lot of times the team means the clinical team. In some iterations of it, it means the clinical team plus patients and families. Okay, so if we take that at face value that we think that maybe there should be a team there, what do we need to achieve in order to make that happen? Common goals, shared situation awareness, shared language and ideas called common ground. Talk to Paul back there about that. He's done a lot of good work there. Coordination mechanisms, leadership and subordination, reliable communication systems, good closed loop communication and feedback adaptation. Are we there yet? No, maybe not, but human factors can help. I've got an example of 2 medication reconciliation scenarios where they're talking at cross purposes. I mean, talk about a lack of common ground. I take the orange and brown one. What is that? And finally, we can think about human factors methods for incident capture and analysis that is attentive to what patients and families experience in the course of care, and maybe shows us a different side of the equation. So these are what we might call the non-routine events, when things deviate from the optimal path and may result in an adverse outcome or may not, but certainly elevate the risk. We can ask patients and family members what they experience, because sometimes the clinician doesn't know, and sometimes the clinician sees different things as deviations from what the patient sees. So we've been doing a study on this. I don't want to spend too much time because we're running out of time. But rather, I want to conclude with some good news and bad news with respect to the contributions of human factors to patient and family engagement. The good news is that this is recognized as an area that human factors can have a fruitful entree into. So this is a National Research Council report that says human factors research is important to things like incorporating home-based devices, technologies, practices, is in fact essential. But if you look at the bottom quote, this is Leonard Kish, who coined the term patient engagement is the blockbuster drug of the century. And he's saying in his blog, there are many resources available from other disciplines to help healthcare move towards patient engagement. Behavioral economists, user experience designers, community leaders, interaction designers, software developers, game designers, risk managers, data scientists, and actuaries. And I don't see industrial engineers on there. I don't see primary care scientists, which is the goal, up there. I don't see human factors engineering up there. I don't see human-computer interaction. I don't see biomedical engineering. And so E-Patient Dave has this cute Midwestern quips, and I've got one for you too. And that is, don't let the actuaries take over the sphere of patient engagement. Let the engineers be involved too. We're at least as useful as actuaries. And with that, maybe we can do some discussing.